Hello, sir. Sir, am I audible? Hello.
You are audible, Ravi.
Yeah, 1 second, Sheetal. I'll make you co-host. Just 1 second.
Yeah.
Sheetal, now it is fine.
Can you all see my slides?
Yes, Sheetal, we see it. We see it.
Okay. Yeah, sir. Please let me know when I need to start.
Yeah, Sheetal. Yeah. I'll just see the Chandra madam has also started joined up. Yes. Madam, can we start, madam?
Start, ma. We'll start.
Yes.
Good afternoon.
Yeah. Good afternoon.
Ma'am, good afternoon.
Good afternoon. Welcome.
Thank
Welcome.
you.
Good, good.
Yeah. Good afternoon, everyone. So today is our fifth session in the series of lectures on the topic of neuropsychiatry border zone disorders. So today the topic of discussion would be on approach to tardive dyskinesias and their management. So this topic would be dealt by Dr. Sheetal, who has done her MBBS and MD General Medicine from Guwahati Medical College, Assam. And she has done her DM in Neurology and PDF in Cognitive Neurosciences from NIMHANS, Bangalore. Currently, she is practicing in Wockhardt Hospital in Mumbai Central. Thank you very much, Dr. Sheetal, for accepting to take up this session on tardive dyskinesias and their management. Over to you, Sheetal.
Yeah, good afternoon, everyone. At the outset, I would like to thank Indian Psychiatry Society Karnataka chapter for giving me this wonderful opportunity. Also, I'm thankful to Professor Chandra ma'am, who is always my mentor, and Dr. Ravi Teja. My topic for today is approach to tardive dyskinesia and its management. And I am Dr. Sheetal Goyal. I am a consultant neurologist in Wockhardt Hospital, Mumbai Central.
Yeah, Sheetal, any problem?
Yeah, slides are not moving. Okay, fine. Got it. So the content of my talk will be under the following heading. First, I'll be discussing in detail about tardive dyskinesia, tardive dyskinesia like withdrawal dyskinesia and dyskinesia in L-DOPA treatment. Coming to introduction, tardive dyskinesia is a syndrome that includes a group of iatrogenic movement disorder caused by the blockage of dopamine receptor. According to DSM-5 criteria, it has been defined as a medication-induced movement disorders that persist despite continuation or the change of medication. I want to clarify here that in the definition, there is no time limit to the start of movement disorder after the drug, and there is no time like it should last till 1 year or it should last till 2 years. So they have not mentioned any kind of time limit to any of this. So it is just a medication-induced movement disorder. Tardive dyskinesia is one of the drug-induced movement disorder. The other movement disorders that we see with such drugs are acute dystonic reaction, Parkinsonism, akathisia, and neuroleptic malignant syndrome. As our talk is today on tardive dyskinesia, I will like to keep myself in this topic. Tardive dyskinesia can manifest as early as 1 to 6 months following the initiation of a dopamine receptor antagonist. Its occurrence is high. Its occurrence is 2 to 5% annually. We have to understand that the occurrence differs on which type of drug has caused tardive dyskinesia. Usually in typical antipsychotics, the prevalence, the association is very high. It is seen on 32.4% of such cases. Whereas if we introduce a patient with atypical antipsychotic, the occurrence comes down to 13.1%. When you will ask that who are more prone for developing tardive dyskinesia, studies showed that individuals who develop acute adverse side effects like acute dystonic reaction in the onset of antipsychotic medications are more prone to develop tardive dyskinesia in the coming future. Prevalence with other medications, which I will be discussing which are those medications, the prevalence is low of only 1 to 10%. Usually they are female predominant with middle to late age. But I want to clarify one thing. There is one kind of tardive dyskinesia, which is known as tardive dystonia, where it is something different. Here the prevalence is more in the males and usually in the middle to young age, not female or middle to late age. So it is just opposite. Longer duration of antipsychotics prone a person to develop tardive dyskinesia in the coming future. I'm not supposed to tell any of the audience here which drug can cause tardive dyskinesia when I put this slide. They all will say, yes, we know it's a typical antipsychotics which make a person prone for tardive dyskinesia. But coming to the next slide, I want to tell there are many other medications which can cause tardive dyskinesia. Those are movement disorder medications where trihexyphenidyl we use day in, day out, which is an anticholinergic, antiemetic, which every one of us, even from MBBS level to DM level, we use in emergency, like metoclopramide injection, which comes in the form of Stemitil brand name, decongestant, which we give to elderly when they come with dry cough and all. Then there are other drugs are second generation antipsychotics, antidepressant, mood stabilizer like lithium, SSRI amitriptyline, Anti-epileptics. Very few knows that anti-epileptics can also cause tardive dyskinesia. Among those, the topmost list lie with phenytoin, lamotrigine, and carbamazepine. If you say, are they very common? I would say no, they are not very common. But if you go through the literatures, you will find many case reports where they have showed the case with on long-term phenytoin use and presented with some amount of movement disorder. So in short, all these medications which I have mentioned above all had their function in dopamine D2 receptor. So all the drugs that somehow one way or the other blocks dopamine D2 receptors are known, or the patient is prone to come with tardive dyskinesia. Now you all must be asking me that there are so many patients, even in psychiatry ward, each and every patient must be on one or the other antipsychotics. Then what are the risk factors that prone a patient to develop tardive dyskinesia? They are older age, female, non-Caucasians. If the patient already is developing drug-induced Parkinson, they are more prone to develop tardive dyskinesia. Already underlying organic brain dysfunction, depot preparation of psychiatry medications, diabetes, affective disorder, lower plasma pyridoxal 5-phosphate, and there are many genetics which are under research which are known to be directly related to tardive dyskinesia. See, coming to pathophysiology, there are many mechanisms which are explained, but one which is constantly explained is that whenever any drug causes blockage of D2 receptor, there is ultimate upregulation of D2 receptor, and which results in post-synaptic receptor supersensitivities, which leads to upregulation of dopamine receptor responsiveness. And compensation supersensitivity of dopamine receptor may develop after long-term blockage, which ultimately leads to tardive dyskinesia. But there are many other papers which say that it is not only dopamine which is responsible for this tardive dyskinesia, but other transmitters also has been studied to play a role for this. That is GABA, glutamate, pre-pro-enkephalin, and acetylcholine. And obviously genetic, as I told. Then what are the clinical features? Now we have learned something about tardive dyskinesia. So how the patient will present to us? Usually they are very stereotypic movement. They will continue with that movement throughout. Either it will be limited to the tongue, or it will involve tongue, neck, it will involve face, or sometimes truncal musculature or limbs. So what I want to tell is that any kind of movement can be tardive dyskinesia. So with seeing the movement, you cannot ensure that it is not tardive dyskinesia. Buccolingual movements are commonly seen, like lips making, tongue protrusion, perioral movement, chewing movement, or puffing of the cheek. So tardive dyskinesia, now as I saw that it can involve any part of the body. Similarly, tardive dyskinesia has a very large range of phenomenology. It starts from stereotypy, dystonia, chorea, tremor, humming, dysphagia, tics, myoclonus, blepharospasm. So again, we can conclude that none of the phenomenology once seen, you cannot say that no, this cannot be tardive dyskinesia because it's this phenomenology, because tardive dyskinesia can have any kind of phenomenology. But whenever it comes to dystonia, many times my junior or MBBS, they always confuse whether it is acute dystonic reaction or it's a dystonia due to tardive dyskinesia. So I have prepared a table speaking on the same. So if you can see my slide, in tardive dystonia, usually it is a gradual onset process. It takes years to develop this kind of dystonia. You will have a long history of antipsychiatric medication, which has led to this kind of dystonia. Focal dystonia with segmental progression. Now I will let you, I'll just give you a brief that what is focal, what is segmental. Focal dystonia is limited either only to the neck or to the hand or to the upper limb. But when you say segmental dystonia, it is the dystonia or abnormal posturing involving two adjacent structure, like patient is having neck and the upper limb dystonia, which are very adjacent to each other, or upper limb and the truncal dystonia. So this leads to segmental form of dystonia. And they may improve, but they never resolve with anticholinergic, and they can have many forms. Whereas when it comes to acute dystonic reaction, it is very abrupt in onset. As it is very abrupt, it goes also abruptly. You are not worried. You just have to counsel the patient that it is just an acute dystonic reaction which will go off. It goes off completely Anticholinergic gives a very good result, and it is focal only. So this is this is the gross difference between the tardive dyskinesia and acute dystonic reaction. These are some of my patients which I have seen in my day-to-day practice. He is a gentleman with a he's a diagnosed case of bipolar disorder. I just want you to look to the perioral region where he's continuously twitching periorally. This is another of my patients. You can see the lips making, classical lips making movement that the lady is having. She was also on antipsychotics. This is a typical rabbit syndrome that we come across in tardive dyskinesia, where there is continuous tremor of the mouth periorally, looks like a rabbit. But this lady also has tongue tremor associated with it. This tongue depressor was kept because I wanted to see whether the uvula also is having tremor, but no, it was not such case. This is another case where patient again had long-standing history, 1 to 2 year history of antipsychotic, and presented to me with lingual dyskinesia. The family members, even the patient told me that the patient never felt any difficulty in chewing or with the food or eating the food, but he continuously used to have this kind of tongue movement. This is a case of tardive blepharospasm. I think there is some issue with the video. This is a case which I saw yesterday. So this is a young boy who was diagnosed with bipolar again, and he was on antipsychotic. Then this is a classical case of segmental dystonia, if you can appreciate. There is
How many?
So there is a it is a segmental dystonia where the involvement is limited to the neck, where the continuously he keeps having retrocolis as well as in the upper limb. So we are planning to give injection bottles for this patient. So how to measure tardive dyskinesia? We got to know how it looks, how it presents, then what drugs are responsible for causing tardive dyskinesia. But when you need to put it in a scale, because our medical, we put everything in the scale, which helps us to understand how severe the condition is. So there are two important scales that are used for tardive dyskinesia. One is abnormal involuntary movement scale, that is AIMS, and another is Pan-Marsan dystonia rating scale if the patient presents with tardive dystonia. In AIMS, it is a very long back scale. It was first used in 1976. But it is still used in many of the big papers. They use AIMS scale to find out the severity of tardive dyskinesia. It was aimed at recording occurrence of tardive dyskinesia, detecting tardive dyskinesia, and it is also good that you can also follow up the severity of tardive dyskinesia over time with this scale. It has got 12 items. I won't go in detail. There are 7 items in the first, which speaks about the different part of the body, and the rest 5 items, they speak about the awareness, means the incapacitation that has occurred because of tardive dyskinesia. This is in brief the scale, where they score from 0 to 4. 0 means no abnormality, and 4 is the severe form of tardive dyskinesia in that part of the body. Then comes the Pan-Marsan dystonia rating scale. This is used not only for tardive dystonia, this is used for any kind of dystonia in our movement disorder. So it is also used to grade the tardive dystonia. It checks for the severity, precipitation of provocation factor. It scores the eye, movement, neck. It scores from top to bottom, just like AIMS scale. So again, we'll not go in detail. This is a Pan-Marsan dystonia scale in short. Now, coming to the investigation, frankly speaking, for tardive dyskinesia, you don't require any kind of investigation. It is only a smart history taking and looking into the drugs that the patient has taken. Why I'm saying so is that many a time patient will be taking some anti-emetic long back, And when he comes to you, he doesn't feel the requirement to tell you that he was on antiemetic for long, or he was cisapride or anything for long, and each get missed, and you are continuously confused that what has caused this kind of movement. So you should be very smart in asking a detailed drug history along with your clinical history that we need in neurology. So now, but still, if you ask me, is imaging required for dyskinesia? Again, I say not really. But if you're suspecting that it may not be tardive dyskinesia, your training says that it can be something else, then to rule out another cause, you might go for imaging. This is something which is used in many centers as a part and parcel to diagnose tardive, to differentiate tardive dyskinesia from other Parkinson disorder. Actually, see, as we read in the book, none of our patient comes like the way it is written in the book. They come in a very bizarre fashion. They come in a very complex fashion. So sometimes very good movement disorder specialists also get very confused whether it is drug-induced movement disorder or it is a part of another genetic movement disorder or Parkinson associated with dystonia or something. So in that case, many paper has come where they speak about the importance of dead SPECT imaging. Again, I say this is not like you have to go for any patient for imaging. Your smart clinical judgment is enough to make a diagnosis. Still, if you are very confused, you can go for dead SPECT imaging, where they help you to understand whether it is drug-induced Parkinson or not. Now you all will be asking me that what dead scan will present in a drug-induced Parkinson with tardive movements disorder. Frankly, it will be a completely normal picture. If it is Parkinson, there will be abnormality seen, and if it is a drug-induced Parkinson with movement disorder, it will be a completely normal picture. So this is one of the imaging that has been used in many higher centers to differentiate between the two. So now, can tardive dyskinesia point towards a specific disorder or dyskinesia? So there are many few, I thought that because I have a talk on this, I should let you know about rare conditions also. So many times we movement disorder specialists, whenever patient comes young age with Parkinson, with movement disorder, very well responding to levodopa, and very soon develops levodopa-induced dyskinesia. This gives us a clue that we are dealing with some genetic associated Parkinson like neuronal intranuclear inclusion body or POLG mutation. Recently, we had a case of young onset Parkinson, very well responded to levodopa. Within few months, developed severe levodopa-induced dyskinesia. On mitochondrial study, we found that he had POLG mutation. So some of the young onset levodopa case, very well responding, having dyskinesia also can give you a clue that you might be dealing with some other kind of disorder. So coming to treatment, as I told you, the first treatment, things are very simple. First treatment, if you got an offending tablet, stop the tablet. The primary, the best treatment is stop that medication if possible, or change it from typical to atypical. So this will be taken care by our psychiatry colleague. But again, if it doesn't work, then what are the treatments available? There are only 2 FDA approved drugs that are used for that can be used for tardive dyskinesia, and all others are off-label drugs. So these two, if you can see, vesicle monoamine transporter 2 inhibitor. Among these, the second and third, that is deuterated tetrabenazine and valbenazine, are FDA approved drugs. And tetrabenazine is an off-label drug. And here vitamin E, B6, amantadine, all are off-label drugs, means they are not FDA approved. So as I told you, valbenazine is FDA approved, tetrabenazine is FDA approved. And now recently, very recently, just in February 17, 2023, tetrabenazine extended release has also been FDA approved. Why it was required? Tetrabenazine needs to be taken twice daily, whereas extended release can be taken just once a day. So it makes life easy, and it has been again FDA approved. So now you will say, wow, it is FDA approved. No other drugs is FDA approved. So how VMAT2 must be working? So I can come to a simple picture here, the diagram, if you can see on the figure number A, this is the normal way our neurons will work. Whenever dopamine is released in the synaptic vesicle, it will be taken back by the dopamine transporter, and through VMAT2 receptor, the dopamine will go back to the synaptic vesicle and get released for performing its function. But when you use VMAT2 inhibitor in the form of valbenazine, deutetrabenazine, or tetrabenazine, it blocks this receptor, as a result of which dopamine cannot go inside the vesicle and cannot act post-synaptically. So in this way, it prevents the abnormal movement that is associated with tardive dyskinesia. Now, many of them will be thinking in their mind, tetrabenazine, as you all know, the famous name is Rivocon. We use it day in, day out. We are not very familiar about deutetrabenazine. We are not very familiar about another drug. So why should I go? So when you compare between tetrabenazine and deutetrabenazine, there is not much difference between the two. The only good thing about deutetrabenazine is that its stability is much more. You can see down in the left and in the right, in tetrabenazine molecule, there are lots of hydrogen molecules. Whereas when it comes to deutetrabenazine, they have removed all the hydrogen molecule and they have put deuterium in its place. So what it lead to? It has lead to its stability. Therefore, the bioavailability is more, half-life is good. So that's why deutetrabenazine is better than tetrabenazine. But yeah, if you use tetrabenazine, I think it's not that I think, the function is almost the same. So there are many studies, recent studies, which have spoke highly about VMAT2 inhibitor. There are lots of systemic review, meta-analysis, and they have found a successful outcome, statistically significant improvement in patients who are using VMAT2. This is a brief account. Both are FDA approved. A bit of difference between the two. Valbenazine can be, it is given once daily at bedtime. Half-life is too much. It is 15 to 22 hours. It has got adverse reaction of sedation, akathisia. And in deutetrabenazine, it has to be given twice daily. Side effect is insomnia. What I want to say is that whenever you're planning to give valbenazine or tetrabenazine to anyone, I request please go for at least one ECG check, because it both has got a side effect of QT prolongation and we don't want to land a patient in trouble. So cardiac clearance should be done for aged people. And like if you say, madam, which we should use, valbenazine or deutetrabenazine, you can see the side effect. If the patient has got insomnia, along with the other disease, if you give them deutetrabenazine, the person will have more sleeping difficulty. So there you can select valbenazine. So this way you can customize according to the patient's need and patient's clinical picture. So these are treatment of tardive dyskinesia with tetrabenazine, valbenazine. There are many, many studies. What are the off-label treatment? Vitamin E is it's a very old study. From long back, it is known that vitamin E can cause improvement in the symptoms of tardive dyskinesia in the dose of 1600 mg per day. Now the mechanism explained behind this, it acts by decreasing the oxidative stress. There is another this is another vitamin E long big meta-analysis done. Then that amantadine comes into picture. Amantadine is also known because it causes dopamine release. Therefore, it is known to decrease tardive dyskinesia. Even in we give it even in case of Parkinson. Then vitamin B6 is also known to as a treatment of tardive dyskinesia. If you ask what is the mechanism behind, it acts as a cofactor for production of dopamine and other neurotransmitter. In this way, it works for the improvement of tardive symptoms. So for now, what to do with retractable dyskinesia? You have done your best, but patient continues to have abnormal dyskinesia, very disabling dyskinesia. So for those, there are options like deep brain stimulation surgery, where we do DBS for bilateral GPI. So bilateral GPI DBS, systemic reviews and all has spoken very high on for such cases. You can see where I have highlighted it. The AIMS was reporting 51 patients with an improvement of 62 plus minus 15%. So it's a big number. And if the patient has come to with tardive dyskinesia dystonia and you have done GPI DBS, the improvement has been 76% around. So it's a very good percent improvement seen with deep brain stimulation surgery. Even long-term study has been done, long-term effect study, which has also given lots of positive reports. So for tardive dystonia, do we have any other management? Yeah. For tardive dystonia, as I'm going through all the papers and letting you know that this has been done in lots of papers has been reporting this successful thing. So successful treatment for tardive lingual dystonia with botulinum is the first paper where they have found that the patient stopped having lingual dystonia after introduction of injection Botox. Then refractory open jaw oromandibular dystonia also got treated with botulinum. There are many papers. I have just quoted 3 papers. So when you get tardive dystonia, which is not responding to anything, you can even try with injection botulinum toxin. Others known which are in the research and many physicians prefer is levetiracetam, propranolol, amino acid supplement, benzodiazepine, calcium channel blocker. So there are many other options off label which you can try. So what about the prognosis? The prognosis is good. Usually, if you stop the offending drug, change it to some other drug, then usually it is seen that the improvement takes time, obviously. Sometimes it takes 6 months to 1 year, but gradually it went off. But many times it doesn't happen so. They continue to have this movement disorder. And usually the worst prognosis is seen with if the tardive dyskinesia is at the onset of while on drug as opposed to withdrawal. At the onset of your drug introduction to the patient, only patient started having tardive symptoms, frequent interruptions, cumulative dose, duration of tardive dystonia while on offending drug. So this was all in brief what I felt I should let you all know today about tardive dyskinesia. But I would also like you all to know that have you heard about withdrawal emergent dyskinesia? So withdrawal emergent dyskinesia is nothing but it is a subtype of tardive dyskinesia. Dyskinetic symptoms which appear shortly after a period of reduction in antipsychotic drug dose. It is just opposite. You are trying to stop the drug and patient starts developing dyskinesia. There is certain criteria to put it into withdrawal emergent dyskinesia. That is, the patient will not display any kind of abnormal movement during antipsychotic, but only during withdrawal the patient will start having abnormal movement. There will be spontaneous improvement 90% of the cases. So you don't need to worry that, oh my God, I should not withdraw the medicine, patient is having movement. No. If you withdraw the drug gradually the patient will get improved in 90% of the cases. And usually they doesn't require any treatment. So please don't get worried. Don't try with Botox. Don't think about the deep brain stimulation. It is very treatable. It goes off its own. So this is one of my case I want to tell. When I was a movement disorder trainee in Hyderabad, so I came across this case. So the history I'll give you in brief before starting the video. Patient was a bipolar case, bipolar disorder patient who was on multiple antipsychotics, SSRI and all, but he did not have any improvement. Therefore, the psychiatrist started him on lithium. So after 1 week, after some 10 days, when the lithium level was checked, it was high. It was above the normal range. As a result of which his lithium was withdrawn. So after 4 to 5 days of withdrawal of lithium, patient came to us in stature in my OPD with this kind of movement disorder.
No, did he have anything to swallow?
So you can see the video which I have made. He could not talk. He was in this condition when he came to us, and it persisted for 1 week. So when he came to us, we were not very aware about withdrawal dyskinesia. So what we did is we did an MRI brain, which was absolutely normal. We did CSF, which was normal. We thought that it might be coincident that his lithium was withdrawal and he had these symptoms. We should send autoimmune. We even sent autoimmune, which was negative. Acanthocytes negative. So ultimately, we had gone through many literature and we came to know that it was nothing but withdrawal dyskinesia, which gradually resolved only on normal saline and on admission after 7 days. And he went walking from our hospital. So this is a classical case of withdrawal dyskinesia. Another entity which I want to tell in brief is tardive dyskinesia with L-DOPA therapy. So response to L-DOPA. always gives us a suggestion that we might be dealing with synucleopathy. We can see with Parkinson, there is 94 to 100% improvement response, 80% in DLBD, all synucleinopathies, they get very nice response. And even those patients are very much prone for L-DOPA dyskinesia. Dyskinesia in Parkinson is not only seen with L-DOPA, it is seen with many other like dopamine agonist, which we give, DBS also can cause dyskinesia. So dyskinesia and dystonia both are common in Parkinson. I won't go in too much in detail. Clinical feature, it affects large group of muscles. For dystonia leads to curling of the toes, etc. I will show you in the video which I have collected. So this is a case of young onset Parkinson with levodopa-induced dyskinesia. You can see the severity of dyskinesia this young boy is having. After 4 to 5 hours of levodopa, when the effect of levodopa goes off, this kind of movement disorder completely vanishes. This is another lady who was under me, 5 years of Parkinson diagnosed. So the husband has made this video to send me and say how she moves when levodopa effect is at its peak. So I'll just show the video. You can see the leg, not in the face, but it is only in the leg. This is involuntary leg movement. This is another levodopa-induced dystonia. This is recently I've seen 1 month back, young girl diagnosed with depression for 2 years, long 2 years, and later developed Parkinson picture. And on proper history, we found that depression was nothing but the non-motor symptom of Parkinson disease. So she has sent me this video. In the morning, she starts having this kind of dystonic posturing of her right lower limb. So again, the pathophysiology behind L-DOPA-induced dyskinesia, which is what type of tardive dyskinesia. So again, a maladaptive mechanism related to dopaminergic and glutaminergic system. There are 3 types of dyskinesia which are known with L-DOPA. This diphasic, peak dose dyskinesia, and off-period dystonia. You must be asking why I need to know all this. This is very important to understand because the treatment plan changes completely. It is just opposite of each other. That's why any patient of Parkinson comes with this kind of dystonia or dyskinesia, you need to first tag that patient to which category he falls, whether it is diphasic, it is peak dose dyskinesia or off-period dyskinesia. So this is the treatment for peak dose where you reduce MAO-B inhibitor, COMT inhibitor, you add dopamine agonist, and you switch from long-acting levodopa formulation to immediate release formulation. In biphasic, again, you reduce MAO-B inhibitor and COMT, you add dopamine agonist, and you consider deep brain stimulation in such cases. But when it is an off-dose dystonia, it is totally opposite. You have to add MAO-B inhibitor and COMT inhibitor. So you know their life, and you can give them an idea about apomorphine pump, inhaled levodopa. So we need to understand first. We have to make a correct diagnosis to treat the patient well in such kind of cases. So this is my last case which I want to show you. This is a case stubborn to give a diagnosis. Patient is still under my follow-up. Again, before showing the video, patient she's a lady. She is 10 years back, she was diagnosed with depression. She was on many antipsychotics also as well. She was on typical antipsychotics. After long 5 years, when her psychiatry medicines almost came down and she was doing good, she started developing dance-like movement, choreiform movements all over the body. Initially, the intensity was low. Gradually, the intensity became more. When she came to me, I thought that it may not be related to antipsychotics. We got the genetics done. Because he went roaming to every hospitals in Mumbai, he got Todard scan done. So none of them could give an answer. So this is something which is I'm still puzzling me, though the patient is doing very well with valproic acid and other supportive measures. Now you must be asking why not tetrabenazine? I tried with tetrabenazine, patient could not tolerate tetrabenazine. She used to feel very sedated. She just didn't like it. And therefore she is doing well now with valproic acid. So this is my patient.
अरे क्या कर रही हो?
This movement is very distressing for her. I got the mitochondrial, I got the whole exome sequence, everything is negative, and she's just on the symptomatic treatment, and I don't have the answer till now for this patient. So my key points today is that tardive dyskinesia can be caused by many group of drugs, not just by typical antipsychotics. Avoid typical antipsychotics as far as possible. Various treatment protocol, including deep brain stimulation surgery and injection botulinum toxin, is available for resistant cases, not on the as the first choice. Anti-withdrawal dyskinesia need to be kept in mind. In levodopa-associated dyskinesia, type need to be ascertained as treatment differ in each type. Thank you.
Thank you very much, Dr. Sheetal. Any comments, suggestions, or questions? There are, I think there is one question in the chat box, Sheetal. Can you take it up?
Yeah. The deutetrabenazine and valbenazine is available in India. If I don't know from where are you asking me this question, but it will be available in India Mart. Some of my patient has gathered the tablet from India Mart also. So it will be available. Yeah, they work for tardive dystonia, but tardive akathisia, akathisia mainly doesn't come under tardive dyskinesia. They are usually subacute or acute, I think. They doesn't fall under the phenomenology of tardive dyskinesia.
Any comments or suggestions from the senior faculty? Chandra madam.
Primary
That
line.
was very nice. The whole topic.
Thank you, ma'am.
But sometimes I think, of course, for the oromandibular and all, we will not be going for DBS.
Yes.
Sometimes
correct.
we find that it doesn't improve at all. That's also the perioral types.
When we give
So
Botox
that's
in such cases.
you have to repeat now. Keep on repeating.
Yes, correct.
How long in a background of a chronic mental illness and Botox also at investor. Not always possible for to keep on repeating now periodically.
True, ma'am. True. Here, one more question is the primary line of treatment. Is it same for tardive dystonia and tardive dyskinesia? Yeah, the primary line of treatment is the same.